Well, what we're going to talk about now is IV therapy, which is a big part of what you guys are going to be doing as licensed nurses out there, okay? The assignment to go with IV therapy is really covered for the most part in the Iggy book, chapter 15. Okay, chapter 15. Now, we're going to talk about a couple of other things that are in other chapters. We're going to talk about TPN. We'll cover that again. And then we're also going to talk about blood administration. And those are in other chapters. I'll get those chapters for you. We're not covering blood today. Okay? But TPN is probably over there with the nutrition part and in the GI part where because we talked about that as part of GI content. So most of the content is going to be in chapter 15. Yes, sir. You guys did not have to buy nurse packs, right? Okay. So you do not have to you don't go buy one, okay? We'll have the things. I'm sorry, I've got a couple of classes and I can't remember who has a nurse pack and who doesn't. So don't go buy one. You don't have to buy one. We'll have the stuff for you, okay? But I do want you to plan on spending some time in the lab before checkoffs. We're going to talk about IVs, how to start IVs and how to draw blood, and we've got some time set aside, is it next Tuesday, I think, to go to the lab, and I'll show you and demonstrate and allow you time to practice those skills. However, it is a skill, and it's something that takes practice. Once you get it, you got it, okay? But it does take practice to get that skill and get your way of doing it. So there are some of you who do need to plan on, spending some time in the lab, practicing with Miss Brown. And if you feel like you do need that extra time, just call them and set up a time, because we're not going to do the checkoffs until that next week. We'll start at that next week. So some of you will check off on the 7th, and some of you will check off on the 14th, and I'll post that. And that's luck of the draw, all right? Okay, so I also posted for you some of the terminology that we're going to be talking about during the IV content, and it's just a whole plethora of things, everything from equipment to complications to terms that we're going to be using when we're documenting our care. So we'll go over these in the span of the conversation, okay? I'm not going to go over them individually right at the moment, but these are some of the things that you need to know. You need to know what some of these abbreviations are, okay? So when we're talking about IV therapy is simply the administration of fluids directly into the venous system, okay? You may also hear it called parenteral therapy. Okay. Bless you. IV therapy can be given in a peripheral IV or peripheral vein, or it may be administered through your central venous system. Okay. So what do you think is the nurse's responsibility with IV therapy? In the broad sense of things. What is the nurse responsible for with IV therapy? She or he is responsible, first of all, for initiating it. Okay? We don't order it, but we start it. We actually do the actual initiation of it. We do the maintenance care of IV therapy. That is what you just told me, monitoring, checking the dressing, checking the site, checking our fluids, checking our I&O. Okay? And then we're also responsible for monitoring the patient. I know Mr. Welch went over with you some of those things that happen when we overhydrate our patient and overload our patient. Our responsibility is making sure that we're not doing that. Okay? So initiation, maintenance, and monitoring. That's the nurse's role in IV therapy. So why in the world would we want to put somebody on IV therapy? Several different reasons. Maybe they need fluids and electrolytes. We can use IV therapy to provide nutrition. We may need to give them blood or blood products. And then we may also need to give them medications through the IV route. But our goal here is to maintain or correct the fluid balance in your patient. So those are your 4 basic reasons why we want to give somebody IV therapy. Now, IV therapy can be, you may be administering it continuously, or it may be intermittent. Okay? So continuous means we're just giving it around the clock. They've got a continuous inflow of fluids. And intermittently is usually if we're giving something like medications just every so often throughout the day, IV antibiotics every 8 hours or every 6 hours. Or it may be that we're just bolusing our patient every so often. Okay? And we'll talk about boluses. Okay? But IV therapy may be long-term or it may be short-term. But again, it depends on why we're giving it and the response of the patient. Now, just like everything else in your practice, IV therapy is governed by a lot of different standards and policies. The main one is your standard of care. Who determines the standard of care for you? Who said that? The nursing who? The nursing thing. Let's narrow that down. The state board. The state board. Your state board determines your standard of practice and determines the Nurse Practice Act. Have you heard those 3 words? Okay? So this is what tells you what you can and you can't do as an RN in the state of Alabama or in the state of Tennessee, wherever you practice. And it's different from state to state. Y'all know that. Okay? So your Nurse Practice Act is what defines your practice and sets the standards for your practice. It's kind of like our Constitution. It's your rules. Sets the standard and the, what else did I say? And defines your practice. Okay. There's also a national organization called the Infusion Nurses Society that also looks at practice and things like that. I'll give you an idea. What our used to best practice, I guess, was that every 48 hours you changed an IV site. Okay, and so, or 72 hours. Every 48 to 72 hours you changed an IV site. We did that for years. So in research and nursing research, as a matter of fact, and through the Infusion Nurses Society, they started looking at that practice. Is that really good? If you've got a good ID, do you want to just yank it out and start another one and just, because sometimes that may be the only IV you could get in that patient. Okay? So through research and looking at best practice, now we change them every 72 to 96 hours. So we're not just yanking them out every other day and restarting them. So these national standards also will play a part in what you're going to do out there. You still are held to your state practice, but that's where some of those things come from, okay? You also have standards from the CDC, okay? You know, anything government-wide is very lengthy and very wordy and very lawyerly. Okay, so you know, it's things just as simple as universal and standard precautions. Okay, wearing your gloves. The CDC has a guideline for IV therapy. It's about 36 pages long. Okay. But it covers peripheral and central IVs. So your hospitals and organizations and state boards are using these guidelines to set policy for you. Okay. You know about the importance of hand washing. You know about the importance of PPE and gloving and all that business. Okay. You know about how to handle sharps and how to dispose of sharps. Okay. And then you're also held accountable for your agency policies. Okay. And every hospital has its own guidelines. Now, they're along the same lines with each other, okay? But what you're able to do in one hospital, you may not be able to do in another one. Okay? So, your RNs are pretty much, they're pretty standard across the board. You guys can handle our IV therapy and do all that business. But a lot of it comes into play when you're having your practical nurses do IV therapy. Okay, for years, PNs were not able to do anything with IVs, and so, but now it's kind of gone around the bend, and PNs are now trained and learn how to start IVs just like you do, and then they're able to do that if that hospital allows them to do it. Okay, state board says they can do it, provided they have extra training and are, checked off on that. Okay, they have to, so you guys are not necessarily checked off once you get to the workplace like PNs are. They have to have extra training. They still get the same training you get here in nursing school, but once they get out, they have to have a little extra training on how to monitor and maintain and how to initiate IV therapy. Okay, so you have to know your organization's policies. Now, PNs do not do anything with central line. They haven't allowed them to do that yet. Okay, so that's only an RN function right there. They can monitor them, but they're not hanging meds and flushing lines and doing all that with central lines. Not a lot of difference. I will tell you though, now Huntsville Hospital has a, I don't know what they call them, but they have a central IV care team. Huh? They have a, and so for central lines, they don't allow anybody but that care team to take care of those central lines. And it has to do with infection rates and controlling infection, and it's a patient safety issue, but that's not that way across everywhere. Okay, so I think that's kind of interesting. It'd be interesting to see what their infection rates do, because remember how we talked about SCIP with preventing complications after surgery. Preventing central line infections is another one of those core measures that came out based on what was happening out there in the workplace. People were getting infections and getting septic and dying because they're getting infections in their central line. Same thing with Foley. So all this stuff kind of goes around. But I'm not aware of any other hospital that has a central line care team. That takes some staffing, and I don't know of anybody else that has that. So make sure that you know what your hospital allows you to do. And so even as students, if you're doing your rotations at Huntsville and you have a central line, they're not going to allow you to do anything with that. So, okay. So when we're talking about IV therapy, this is a medication. They're drugs, and the same rules apply to IV therapy as do any other medication. Okay? So physician has to order it. and it has to specify those other things that you require in order to accept an medication order. It has to be the type, okay? They need to specify any kind of additives that they want in it, how much, and then how fast to give it. So if you'll look at the bottom there, that's an example of a correct IV therapy order. 1,000 milliliters of D5W with 20 milliequivalents of KCl at 125 milliliters an hour. Other examples that you may see, give a bolus of normal saline, 500 cc's over 1 hour. Now, what's wrong with that order right there? What do you see is wrong with that order? But I hear CC. What's wrong with CC? We don't use that anymore. Okay, so we don't use it. We have to use milliliters. Okay. It doesn't give your infusion rate, but what about this one? It's a bolus, and what does a bolus mean? It's just a sudden inflow of fluids, and they give you, the physician gives you how much to infuse and what your time frame is. So you figure out the rate. So what am I going to set my pump at? You're going to set your pump at 500 an hour. Right. Now a bolus like that, they give you a time frame, okay? Where you're going to give boluses if you have a patient who, why would I want to give just a sudden inflow? You tell me. Why would I want to give just a sudden inflow of fluids? Maybe they're dehydrated, and what else? Maybe to flush pain medicine, maybe not quite 500 milliliters for that, but you may flush it quickly, right? But you think about it, if you've got an elderly person that is severely dehydrated, okay, you may rehydrate them kind of in boluses because they may not, with congestive heart failure and all that business, they may not can handle a continuous inflow of, 300 milliliters an hour. You may bolus them, wait a little while, bolus them. It may be an issue with renal failure. They give them time to take care of that extra fluid that we're giving. So boluses can be given in for different reasons. But this one, that's a correct order. That's a correct order, okay? You just are having to figure out the reason, the rate. Now, looking at the next one, IV fluids D5 1/2 NS at 200 milliliters an hour for 1 liter, then 125 milliliters an hour. Sometimes your physician may not specify to you how much fluid to hang. Okay, that's your choice. That can be your choice. Okay, in the first one here, all you're going to infuse is 500 milliliters. So you can hang a 500 milliliter bag. Or if your patient already has fluid hanging up there, you just crank it up to 500 for an hour and then cut it back down. Okay. Sometimes they've already got fluids going and we just, jack it up for a little while and cut it back down. Okay. This one right here, you're giving 200 milliliters an hour times 1 liter, then 125 milliliters an hour. What would you hang with that one? IVs come in all different sizes. Just hang you a 1,000 cc bag up there. 1,000 milliliter bag, excuse me. Hang that. What am I going to set my pump at? 200 an hour And when that one is out, then what am I going to do? Hang another bag of D5.5, and then what am I going to set my pump at? 125, right. Sometimes, y'all, those orders will be kind of convoluted, and you'll have to have a vote to see what you think the physician needs. Okay, and if you can't come to a consensus, what are you going to do? Call the physician and say, what do you want me? And I've even had a physician write it and come to me and say, okay, here's what I mean by that. And have to, it just saves him a phone call. Just saves him a phone call. So make sure that you understand what they mean, okay? And the third one, your physician does say how many milliliters to hang, okay? 1,000 milliliters of lactated ringers with 10 units of Pitocin. What in the world is Pitocin for? Contractions, okay. And you want to titrate it per protocol for induction of labor. So the reason that we need to know how much to hang in this is because your concentration is affected. You see what I'm saying? My concentration is affected if I hang 1,000 milliliters with 10 versus 250 milliliters with 10. Okay. And I'm sure you guys have talked about in 106 that you have protocols for induction of labor. Okay. They usually will have their standard mixture, what they're going to hang, and then how they're going to titrate it. Okay. So if you have a mixture and titrating, they have to tell you how much to mix it in. And if you have a protocol, that tells you how much. Sometimes your physicians may order an IV med to be given at KVO or TKO. That means keep vein open or to keep open. Different physicians, different hospitals, but that usually means we've just got a continuous IV infusing in case we need IV access. Okay, and usually your pump is set to anywhere from 10 to 30 milliliters an hour. Depends on your organization. It's 20 at my hospital, but I think some places use 10, some use 30. I will not ask you that, but if I tell you KVO, I expect you to know it's at a slow rate, okay? So when we're talking about the types of IV fluids, know that they come in all sorts of brands and mixtures and sizes. There's really about over 200 different kinds of IV fluids that you can choose from. You are not going to be giving all 200 throughout your career, I'm just telling you. You really have to be working in some kind of wild IV therapy place or something. You're going to have pretty much your standards, and we're going to talk about those, okay? But they come in different size bags. Some come in bottles, okay? Glass is going to be required if you're using certain types of fluids, things like nitroglycerin. A nitroglycerin drip has to be hung in a glass bottle. The majority of yours are going to come in these type bags right here. Do what? Because nitroglycerin and some of your other things like insulin adhere to plastic. The thing that you have to know if you're giving something in a glass bottle is that you have to have a specific type of tubing that has an air vent in it. And when we go to the lab, I'll show you that. Okay, so that you see. Most of your tubing now just automatically has an air vent, which just makes it wonderful. Somebody should have thought of that about 30 years ago, because you were always looking for vented tubing. Because the bags will collapse as they empty. The bottles won't do that. That's why you have to have an air vent so air comes in. And if you don't have an air vent, your medication won't infuse. You got to have air going in for it to drop out. But most of your stuff is going to come in bags. your bags usually will have either an access port on here, or either there will be two down here at the bottom, one for access and one for your tubing. Okay. I don't like this picture. I had a better picture. I'm not going to have to. Okay. So, you always want to make sure that when you have your plastic bags that you're checking for leaks, cracks. Most of your bags will come in an outer plastic covering that I think is made by the devil, because you have to be like superhuman to open some of those. But when you open them, your bags there'll be a little bit of moisture in those plastic outer bags. That's normal. But what you want to do is you want to squeeze your IV bag to make sure it's not fluid coming from your bag. Okay. So squeeze your bag to make sure there's no leaks, no cracks. Look at your fluid, make sure that it's clear. Okay. And again, some of the things that we do not want to give in plastic bags is nitroglycerin. We don't give Ativan or lorazepam in a plastic bag. No fats or fat-soluble medications or lipid-based medications. And don't ask me for an example because I can't give you one this time. Ativan or lorazepam. Yeah, same med. Insulin, we don't give in plastic. Sometimes you will see an insulin drip in plastic, but sometimes you may be instructed to add insulin to a plastic bag. That may be a special type of bag, so just be careful with that one, okay? All right. So IV fluid, what in the world is in it? There's my picture I wanted right there. I'm sorry. I'm ahead of y'all in my notes. See this one right here? This one has got, all of these bags have got a place for your tubing. Okay? This one right here has a port to where if you're going to put medication in this bag, this is where you do it. Okay, so some of the bags that you may be playing with next week will have two of these down here. Please don't try to spike that right there. You'll work yourself to death. Okay, most of these take a needle, okay, to go up in there. You know, most of the things you use now don't have needles, but these still do. These are still rubberized. You just got to make sure that when you stick your needle in there, you don't poke it through the back of the bag. Okay, so there's your tubing part. That's for your medication part. Okay. Nope, that's not right. Sorry about that. So what kind of fluid? All right. When we're talking about IV fluids, we're talking about specific combinations of water, sugar, sodium chloride, and or other electrolytes. And these are ordered. The physician will order the kind and the combination that they want. And that the kind they want is going to be based on what the patient's condition is and why we're giving it. Right. So we may be giving our patient an isotonic solution. This is a solution that supplies balanced amounts of water and sodium chloride. Mm-hmm. Okay, got it, everybody? Okay. So what you have is you have equal movement of water into and out of your cells. When we're talking about tonicity of fluids, we're talking about the measure and concentration of electrolytes that's in the fluid. Okay, so isotonic means it's equal, balanced amounts of sodium chloride and water. We use this for extracellular volume replacement when your patient has had vomiting and has had fluid loss. If your patient is hypovolemic and hypotensive. With isotonic solutions, when you administer those, your fluid stays in the vascular system. Okay? So if I'm giving a lot of isotonic fluid to my patient, what can I get in trouble with? Fluid volume overload. Right. Right, because it stays in the vascular system. We also use isotonic with blood infusions. So types here are, and these are your most common ones you're given. Normal saline, D5W, which is a 5% dextrose in water solution, or lactated ringers. Lactated ringers is a solution that has a mixture of different kinds of electrolytes. It has sodium and potassium, calcium, chloride, and lactate. Yes, lactated ringers is more often used with surgical patients. Okay? So saline, D5W, and LR are going to be your most common isotonics. Equal movement in and out of the cells. You don't have a lot of dehydration of the cells or blowing up of your red blood cells. Okay? You may be asked to give hypertonic solutions, and these are the ones who have a greater concentration of electrolytes than what's in the body. So what it does is it's very hypertonic. So when we put it into the blood system, it causes water to leave the cells and come into the vascular system. Remember, it's trying to dilute it. So it increases the blood volume. And we're going to use these when there is excess losses of sodium and chloride. Okay. We're using these to correct fluid and electrolyte and acid-base imbalances. This is a little more, I don't want to say invasive, but it works at the cellular level. We're not just expanding the blood volume, or the vascular volume, intravascular volume like we are with isotonics. Now we're actually pulling water into the vascular system. Okay? These are your types. D10W, D5 normal saline, D5 1/2 normal saline, which is that 0.45%, D5LR, and parenteral nutrition, TPN. So with hypertonics, what we can get into an even bigger issue with pulmonary edema and fluid overload. and we need to make sure that we're watching our blood pressures. We're using this to stabilize blood pressure and help to perfuse the kidneys a little more. Okay, increase urinary output, reduce edema. If you've got somebody who's got a lot of swelling, okay, by giving a hypertonic solution, it's pulling the fluid out of the tissues into the vascular system, and hopefully your patient is excreting it urine-wise. Okay. And increase urine output. You may. You just have to be careful. Yeah, you may. You may have to give it. Depends on what's going on with your patient. Sodium and chloride. And to help correct fluid and electrolyte imbalances and acid-base problems. Sure. But if you're using that with diuretics, what are you really going to? You really can dry them out. Hence, why we got to watch our INO, watch our blood pressures, those kind of things. Okay, so hypertonic, pulling it out of the cells. So what happens is your cells kind of shrink. Okay. Draws that fluid out and pulls it back into the vascular space. Now, hypotonic is the other end of the spectrum. The concentration of electrolytes in these fluids is less than what's found in the body. And what it does is this fluid shifts out of the capillaries and into the tissues, so your blood volume decreases. Okay. This is when you have this is more than just dehydration. Okay, you really got some. You've had we can do isotonic, but when you've got a lot of you've over diuresed your patient. Maybe your patient is a dialysis patient and we've pulled out too much fluid. This is when we're going to start using the hypotonic. Okay. Fluid shifts out of the capillaries into the tissues, and you decrease your blood volume, but you hydrate your cells. Okay. And 1/2 normal saline is your standard there. We're going to use this one when there has been intracellular dehydration. And again, whose decision is it what kind to use? It's the doctor's, correct. You're monitoring for these things. Okay. Good. So dilutes the extracellular and rehydrates the cells. So this is when we're gonna try hypotonic when there has been excessive fluid loss. No, it's a medication. You have to have a doctor's order for having it. So the way I look at it is that when you're giving normal saline, your patient may be a little bit dehydrated, need a little bit more volume, but when we're starting to go to the hypotonic solutions, your patient has got dehydration at the cellular level. Okay, they need more than just intravascular volume. We need to get fluid to the cell. Okay. So your cells rehydrate. Out of the intravascular volume. Okay. All right. I'm going to go back a few slides because I just kind of wanted to show you this. Because apparently mine are out of whack. I didn't catch this yesterday. Sorry. This one. This is kind of just gives you an idea of what the electrolytes are in some of these fluids that we talked about. I will not ask you what the sodium content of normal saline is. So before you go out there and try to memorize this chart, don't. You don't care. You really don't. As a nurse, you don't. Okay? But I do want you to know that normal saline is isotonic. Okay? If you have the option of, if I ask you to choose a hypertonic solution, I expect you to be able to choose from 4. Okay? So these are your main ones here. No, that's not it. You've got it on camera. It's here. I'm recording. Yes, ma'am. But it's the ones we talked about. Okay? All right. So iso, hyper, and hypo. Those are your 3. Other types of fluids. TPN, total parenteral nutrition. Is something that we've talked about a couple of times already. And it is usually hypertonic in nature. So again, we've got to watch fluid overload for folks that are getting TPN. But TPN is nutrition, IV nutrition for your patient. It is nutritionally adequate to sustain your patient. And it just contains all those things that they need to survive. Glucose, other nutrients and electrolytes, and TPN is always given through a central line. And when I say a central line, that means a line that is directly into the central circulation. Each of your organizations is going to have a pretty specific policy on how to administer TPN. This is an RN job as well. TPN is a big deal. It is something that your patient can get very sick if we don't monitor it correctly. What is it about TPN that puts our patient at risk? Correct. Yeah. It's got high concentrations of electrolytes, glucose, and we're dumping it directly into the central circulation so they can have consequences quickly. Okay? These people can get septic if you don't monitor them, because glucose is the basis for TPN. And usually D10W is the basis, and bacteria love sugar. So when you're hanging TPN, you're hanging it under sterile aseptic procedures. You are masked, you are gloved, you're not walking down the hall spiking the bag. You are in a room where there's not a lot of traffic. Okay. So infection control is a huge issue with TPN. Central circulation. Oh yeah, you have to look out for any kind of electrolyte imbalance. Now, the way this stuff, the physician orders the concentration that they want, okay, of whatever, or they'll order. They may have pharmacy, and I'm not talking of pharmacy tech. I'm talking of pharmacists to come out, look at that patient, look at the patient's labs, conditions, things, and then let them design a TPN course of action for the patient that is patient driven. Some patients require more insulin. Some will require more sodium. You know, it just depends on. There's that. It depends. Y'all notice how much we say that. It just depends on what's going on with the patient. So it's ordered, and then it comes to you, or is administered to the patient in sequential order. So each of your bags will be numbered, and you give them in those orders, and we document them in that order. It's your responsibility before you hang that bag to make sure that the contents that are in there is the contents that are ordered for the patient, because it may change. Formula A for this bag, Formula B for this one. You just got to look and see. And a lot of places have a specific documentation form for administration of TPN. It's a big deal. Big deal. Got to make sure you're following that protocol. We give them in order. We monitor that. Every time TPN cannot hang for more than 24 hours. It's an infection control issue. Every time you hang a new bag of TPN, you put new tubing on it. So we don't leave bags hanging. We don't leave reused tubing. And we do not ever piggyback anything into TPN except for lipids. TPN doesn't have lipids in it. It doesn't have the fats in it. So that'll be something that you may have to hang separately, and it is okay to piggyback that into your TPN line, but only that. Lipids are usually ordered once a day, like a once-a-day infusion, or maybe Q12 hours. We don't overload them with fats, okay? But it comes out, it will be separate. The thing about it is if I'm hanging a piggyback on a pump, what happens to my primary fluid? It stops. It stops. Do y'all understand that, the way that works? Tell me if you don't, because now's the time. Okay. All right. When you have an IV, y'all know ARC's not. Okay, here's my pump. Okay, and I have my bag hanging here. And it comes down to my pump, and it comes down to my patient. Okay? This is TPN here. Alright, we got a thing here. Okay. If I hang, that's a port. Okay. If I'm going to hang something, which I can only hang what to this? Lipids, nothing else. I don't care what it is. Don't puncture this with anything else. I've got my lipid bottle here. Okay? Alright. If I hook this to here, and I have this set at 50 an hour, what's going to run? The lipid will run. If this is power, the lipid will run. Okay? What does this do? It stops. You don't ever want to have your TPN stop for any length of time. Remember I said it's loaded with sugar? What happens if we suddenly cut your patient's sugar off? What happens to their blood sugar? It drops. It bottoms out. It bottoms out. So we don't want this to stop just because we got that going. So either we've got to set our pump for 2 simultaneous infusions, or we get us another pump over here, okay, and run this at 25, whatever you want it as, whatever you decide. And I'm going to hook it to here, and then I'm going to hook it down here. Because I want this to be controlled by this pump, not this pump. Does that make sense? If you hook this up here, it's going to be controlled by this. I don't care what, this is going to be beeping all the time. And you're going to be wondering, what is going on with this thing? I got things to do than chase these people. So look at the way you've got it hooked up. And this is the same thing and the same hookup that you want to do if you want to use heparin. Okay? Or any kind of piggyback that you want to keep your primary infusing. You either have to set it as to run concurrent if your pump does that, or if your pump does not do that, and a lot of pumps these days do run concurrent, then you've got to, or you've got to get you another pump. Now, what happens if I have a patient, they got this going. Okay, let's say they've got this going just like this. Your patient also has an order for normal saline at KBO, and they're going to be getting amoxicillin Q8 hours. What am I going to do there? Rhonda says I need to put it in another side. Is that what I need to do? Put your normal saline here. Okay? And then I can run my piggyback here. Because it doesn't matter if that stops while this is running. Okay? But you need another site here. And this shouldn't be a hand, it really should be a neck or something right here. Okay? But yeah, so you got to think about, what am I infusing? What is compatible? Okay? And how do I need to hook it up? You will walk into a med-surg room sometime and there'll be 4 pumps sitting there and you think you've walked into ICU, but you haven't. You just got a patient that's getting loads of fun. Okay? So, but think about it. Nothing goes with that except for lipids. Okay? Yes. Yeah, it has 2 different pump calculations. Correct. Correct. Nothing can go in this line except for lipids. This is just regular IV fluids. Yeah. Your patient may have IV fluids and antibiotics and a heparin drip. Fun on this side, and then they've also got TPN going. You think about those folks that we talked about that had a gastrectomy or had this radical neck surgery. They need IV fluids. They need antibiotics. They're at risk for DVT, so we've probably got them on some anticoagulants. And then we're not feeding them, so we may have them on IV stuff too. Okay? What is the difference between a PICC line and a central line? They're central lines, but a PICC line is peripherally inserted central catheter. So you're getting it central line. You're putting it in peripheral. Let me say that. Sorry about that. I'm having like a stroke or something up here. You're putting it in peripherally, but it's threaded all the way up into the central circulation. Okay, why did she have that? Thank you. She had 2 lumens. She had 2 lumens. Okay? Some facilities will allow you to do that. Okay? That you can have 2 lumens. Do you understand what I mean by that? That means down the inside of your cube, if you cut that cube in half, you've got a lumen right there and a lumen right there, and never the twain shall meet. One of them comes out at the end, the other one may come out up higher than that. You may have a triple lumen. I'll show you that when we start talking about triple lumens. Huh? That's right. That's right. I love these. Love these. If you take care of them, they're fabulous. But you may have triple lumens, but they don't mix. They don't mix. But a lot of your picks are 2 lumens. Now, you can give PPN, which is parenteral nutrition. That is given in a peripheral line. It's just your makeup is a little different, okay? And you're still concerned with some of the things that we talked about, okay? But it's not the, it doesn't carry the huge risk factors like your TPN does, okay? I'm not asking you about PPN at this point. I want you to get this concept. Yes, ma'am. What? I have no clue. You have to look that up. I don't know. Clinomix. I would say PPN, but I don't know. Where was it using it? Peripheral. If it's in her hand, that's peripheral. They don't usually put picks here. Picks are usually here or up here. Wow. So she was kind of fun to look at all them cubes, huh? She had lots going on. Yeah. But you just have to be very, very careful with your TPN, that you're giving it an order, you're keeping it sterile, okay, and you don't let it run out. Remember you just told me that if it runs out and we stop it, their blood sugar goes to the bottom, okay? So what happens is you have to monitor this and keep up with when this is going to be running out, okay? When it runs out, you need to have your next bag ready and available to hang. If you do not, then you're going to need to hang D10W at the same rate that your TPN is going. Okay, and that's probably in your protocols. Okay. D10W. If your TPN runs out and you don't have the next bottle in sequence, and it's not coming immediately. D10W. Because remember, that's the basis, and that's the basis of most of your TPNs. Now, they use other things, but, if you hang D10 at the same rate, that should maintain your patient's blood sugar, excuse me, until you can get the next bag there. With TPN, you're monitoring blood levels, electrolyte levels, at least a couple times a day. But you're monitoring their glucose like sliding scale. How often is sliding scale usually? 4 times a day. Usually it's before meals and at bedtime. 9, 1, 5, and 9 is kind of standard. Okay, it can always change. But usually with TPN, you're monitoring at least 4 times a day, maybe every 6 hours, maybe every 4 hours. It depends what's going on with your patient. How brittle are they? Okay. But you are monitoring and covering their sugar needs with insulin, sliding scale. All right. Questions about that? I'm pretty much done talking about TPN. Yes. Uh-huh. How do you think you're going to discontinue? You tell me how you, it's got to be gradual. You're going to gradually slow down their TPN to take them off, okay? And then hopefully by the time you get to the end, we can start some PO. Yes. So we never just say, that's it, we're disconnecting you and you're done. Okay, you better have some sugar there with you. Okay, but gradually decreasing it, monitoring your patient, and then hopefully we can start some PO nutrition once they've come off of it. Electrolytes, you're monitoring their electrolytes. Remember, your patient's not eating, so we've got to monitor all those electrolytes. You have to monitor INO. You have to monitor that. You're weighing your patients. Jennifer, sometimes while they're slowing it down, they may try to introduce some fluids as they get toward the end of it. So you may be actually trying to get your patient fed while they've still got TPN going. That happens too. But they're going to alter that makeup. Yeah, they're going to alter the makeup for diabetes. You just have to control that with their sliding scale. I have had D5W used in that case, but most of the time it's D10. She was asking about using TPN for diabetics. Yeah, I mean, you got to feed diabetics too. Okay, so, but the makeup of their TPN will be maybe a little bit different. Again, that's not your call. You're monitoring, and you're making sure that you're hanging what is with them. Okay. If you have a PharmD, like a pharmacist, not a farm tech, but somebody who has that is a pharmacist, they have that clinical background too. Yeah, and that just kind of throws the problem with that, and really it's the only problem that I've ever seen, is that it just puts another person into the mix, okay, and it puts another step in your process. So luckily we don't have that all the time, but you've got somebody monitoring just that TPN. Yeah. So again, you just have to be, cognizant of that fact, and hopefully you got it in report that their TPN has been changed and we're waiting on the next bag, or the next bag is in there. This is not something you can just kind of, if it's like got that much in it, that you can cut it down and wait till the next one comes along. Yeah. Okay, any other questions about TPN? Okay. All right. Y'all need a break? Yeah, let's take a break. All right. Okay. Now, when we're talking about equipment and supplies for IV therapy, the main thing that you need to do is be familiar with what is used in your organization. Okay? They vary from place to place, just like a lot of your supplies will. But one of the basic things that you're going to need for IV therapy is a pump. Okay, they come in all sorts of sizes and styles and capabilities. They most of them now are electronic with a battery backup. That way, if you can unplug it and take it with you if you have to transfer your patient to another unit or to radiology or whatever. Okay, and it'll maintain the battery for a while. But what happens is you have to make sure that when these things are not in use that they're plugged up somewhere. Okay, so your battery is always ready. Some of your pumps are able to infuse more than one solution at a time, like we talked about. They can run concurrently. And I don't think I made it, apparently I didn't make it very, you didn't know. I can't think of the word I'm thinking of. But when you have your pump and you've got two fluids coming in, you usually have like a channel A and a channel B. So you have two tubings running in, okay? And you set channel A for how fast you want it to go, and channel B for how fast you want it to go. So this may be your TPN and your lipids, or however you set it up. You are the nurse, okay? But it usually will have the two settings. You may even have two windows here, so you can see A and B. Okay. You may have pumps that have a syringe infuser. So rather than having to hang a piggyback up here, you can take your syringe and put your syringe right here, and it automatically does your IV push for you. Those are fantabulous if you have those. Oh, most of them are needless now. Okay, so it just depends on your pumps. This right here is a whole wad of pumps for all different kinds of monitoring, and that you don't usually see those at the bedside dental med surg unit. Okay, you'll see these and these and these. Okay, so this right here is a different kind of syringe pump, and I know it's a little fuzzy, but these are fabulous. These are all battery operated. You just put a couple of C batteries in it, and your syringe is right here. This is the plunger, and you set it to infuse over 30 minutes, and it just gradually over 30 minutes will infuse, or however fast you want to infuse it. It's great. It's great. We had these at my hospital, and we got rid of them. I swear I thought people were going to riot. It was horrible. They love these little old things. Because they could just take them with them whenever they needed to do a push, and they didn't have to stand at bedside for 10 minutes to push whatever. Okay, so it's great. All right. What do I have? What? No, you can infuse all this stuff at the same time. Depends on your lines that you have, and what's compatible and what's not. Now, TPN, no, you don't transfuse anything with blood either, but we'll get to blood. So you're going to if you're putting in a medication right after another medication as far as an IV piggyback, what do you have to make sure? That your line is flushed, or that they're compatible, that they're not going to cement in the tubing. Okay. But yeah, you can infuse things at the same time and in the same tubing. Your pumps have a variety of alarms that you can set. Alarm management is a huge deal with patient safety now. We are no longer able to go in and just cut an alarm off because we're tired of hearing it. Okay? We have to make sure that everything is correct, right? Patients do have pumps at home. People do go home on IV therapy at home. So again, they need to know about the alarms, and the more advanced we get, the more sensitive your pumps are. There can just be a little piece of fuzz on the outside of your tubing, and it'll alarm that you've got air or something in there. So can be aggravating, but again, we can't just shut them off anymore. We have to make sure that they're good and the patient's good. It is still, even though we have a patient on a pump, it's still your responsibility as the nurse to make sure that it is set correctly, that it's working correctly, and everything, the IV and everything, everything's correct. Okay, you're responsible for the monitoring of it. Remember, that's your role. Now, sometimes you may not need an IV pump, and there are controllers out there that you can use. You have to be very careful if you're trying to make a decision on who needs a pump versus who doesn't. You know, you get really, some of your smaller hospitals in the dead of winter, and we've got RSV, and we've got all these people that are sicker than 40 dogs, and everybody needs a pump, and this, you know, you may not have enough pumps for all your IV fluids that need to be infusing. So you have to make a determination on who can do without a pump. Give me some examples of someone who that must have a pump. TPN must be on a pump. What else? Blood. We used to not put blood on a pump, we didn't. What else? Who would need to be on a pump? Renal failures, your people that you're really watching their intake. Okay? Your very elderly people with congestive heart failure. Your children, infants, must be on a pump. Okay? People who are getting titrated medications have to be on a pump. I'm talking your dopamine, your antihypertensives, your Pitocin, your heparin. All of those critical drugs must be on a pump. Antihypertensives, dopamine, your cardiac care meds. Anything that's being titrated has to be on a pump. If you're told otherwise, you need to write that down as an order. Okay? But when we have controllers out there, sometimes your IV rate can just be controlled with the roller clamp. Remember when you were doing drops per minute? How did you control it? With that roller clamp, right. If I roll it down, what happens to my fluid? Right, and up opens it up. Right, good. This here is called a dial-a-flow. This is one, right? It's two. There are two of them. But what you have with this is this goes to your fluid, okay, and this one goes to your tubing. Okay, I meant to bring one of those. I'll show you one when we go next week. But what happens is you twist this thing, and it's like a roller clamp, except it's a little more high tech. But you move this line to how fast you want your fluid to run. So if it's KVO, you set it at 20. So this is a little addition to your IV tubing. Okay, it goes between the patient and the tubing. And you can control it that way. Pretty neat. And they work pretty well. Can they be defective? Of course they can. It's a piece of equipment. So that's why you still have to monitor how fast your fluids are going. So it never hurts to, when you hook a patient up to a dial-a-flow, to stand there and count, just like you know how to do. Okay? To make sure that it is accurate. Will it be off a drip or two? Maybe. That's not the end of the world. Because remember, we're only going to have people on these things that are able to handle if there is a little extra fluid. Okay? Got to be careful with that. Okay? All right. You have to have tubing, of course. This is just your regular old primary tubing. What's the difference between primary and secondary tubing? Do you remember? The amount of fluid. They don't have more lumens. They have more ports. They have more ports. Okay. Okay. Go for it, girl. Go for it. But it has more ports. Your primary tubing is this. Is this long tubing that it usually has a roller clamp. Okay. This is what goes into your IV fluid and is threaded into your pump. It's longer. It'll have anywhere from 2, 3 ports on it. There's your port. Y'all remember seeing those? Okay. So primary tubing, some of them may just have a couple of ports. Okay. It just depends on what your place uses. Okay. But they should all have a drip chamber. They'll have a little backflow filter, and then you've got your ports, and then you've got your roller clamp. Okay. Primary tubing is the longer stuff, and this is what goes directly to your patient. This goes in the thing here. Secondary tubing usually does not have a port to it, but we connect it to our primary. So your tubing is generally needleless, and it'll vary a little bit based on the device and the pumps that you use. Okay? Some of the pumps will have a little thing that you thread your tubing into the pump and it stretches. That's how it automatically, there's a rotator thing in there that infuses it at what you've got it set at, okay? Secondary tubing is used for piggybacks, right? Secondary tubing is not something that you thread into a pump. Remember, it's about this long, right? So you can't put that in the pump. That goes up here. And it's in up here. Okay. Your IV pig, your pump tubing, your primary tubing, your secondary tubing can usually be changed out every 72 to 96 hours. You can reuse secondary tubing. Again, you have to make sure, though, that what you're using and what you're flowing through there is compatible with what you put through it before. You guys did piggyback and prime tubing and did all that as well before, didn't you? You talked about it? Let's just go with no. Okay, we'll go with no then. Okay. All right. Okay, well, that's something I need to know. We'll go over that next week. Not a problem. But when you spike your bag, whether it's a piggy bag or your primary fluid, what's the first thing that you have to do? Which we call what? We have to prime our tubing. Please give your patient fluid and not air. That's kind of like rule number 1. Okay, so once you spike your bag, you have to prime your tubing, which means get all this air out. Okay, and we'll practice with that next week. So when I have a piggyback and I spike my piggyback, I have to prime that tubing as well, right? Yes, ma'am. Yes. 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 And let me tell you why. She asked, do you squeeze the drip chamber before you prime it? The reason you do that is because if you don't have fluid in this, at least to cover that outlet right there, you get air all the way down your tubing. So clamp your tubing off, clamp it, spike your bag, and then hang your bag up. Right? Squeeze this to get, don't fill it all the way up because that's my pet peeve. That drives me insane. Fill it up, about halfway or, a third of the way. I don't care. I'm not measuring it, but just, you got to see it drip is my point, okay? Once you do that and you squeeze that, now when you open it up, you've got fluid running down through here. It's not a huge issue when you get air down here because you can flush it out when you've got 1,000 cc's to play with up here. But if all you've got is a 50 cc bag that has got your antibiotic in it, and you've got bubbles all the way down your tubing, how you gonna flush that out? You're flushing your medicine out, and you've taken a medication that's probably about $300 worth, and your patient is only getting about 50 milligrams. You see what I'm saying? So that's why I say squeeze the drip chamber, then prime your tubing. I see people not do that, and I don't know how they can do it and not get air all the way down. It must be an art, and I'm not that talented. So just don't waste your patient's meds. But you've got to prime your tubing. There are different types of tubing based on TPN has a special type of tubing. We don't just use regular old IV tubing. It has certain filters in it. Blood has specific tubing. Dialysis has specific stuff. You also remember we talked about IV therapy can be done intermittently or continuously. So when we have IV therapy that's intermittently, we usually give those fluids through what we call a saline lock. Have you heard of that? Good, okay. That's basically an IV that we've started, a peripheral IV that we've started, and instead of having all this rigmarole hanging up above the patient's head, we usually have just a very short tubing that is connected to their hub right there, and this is what we inject their medicine through. Well, what do I have to do to this before I put this to my patient? I have to prime this too. Most of your IVs now will have this on there. They start the IV, they connect this, and then they'll connect the tubing to this. That way, if your patient no longer needs their IV fluids, you can just unhook it here. And then you still got your IV access. You see what I'm saying? Okay. It's kind of hard to do this without playing with the arm. But you've got to prime these, hook them to your patient, and then they're left in. You can always change your IV tubing at the hub down here, but every time you're starting that you manipulate your IV catheter, you have a risk for infiltrating and getting it out of place. So these are fabulous. These are great. Use these. These are called extension tubings. These usually about the same, 72 to 96 hours, based on your hospital policy. If you change sites, if you have to take this one out and change it, getting used to everything. That's just 72 to 96 hours, unless your hospital says otherwise. But routinely, we're changing tubings every 3 days. That is considered a saline lock because all we do is we flush these usually once a shift to make sure that they stay patent. Okay, and we just flush them with 10 cc's of saline. With saline lock medications, you're going to flush before to make sure they're patent. You're going to infuse your medication or push your medication, whatever your order is. and then you're going to flush again to get the medication out of this tubing and out of your patient's IV catheter. Okay, so before and after every medication, or around, every shift or every 8 hours, to keep it patent. Okay. No. The only difference is with heparin locks, you're flushing it with heparin. And it's a small amount of heparin, which is what we used to do. Everybody got a heparin lock. But through research, nursing research I might add, patients didn't need that extra heparin, plus the fact that it was not keeping your catheters patent any more than just plain old saline, if you use good technique and flush it like you're supposed to. Okay? Your tubing usually like I said, is needleless. Okay, we don't need needles anymore to puncture our IV tubing or in our ports. But look at this right here. See this is your port here. If you need to add something to your bag, that does require a needle. And I'm telling you, if you stick that with a needle right there, it's done. It will leak. You have to change that. And this right here is a backflow cap that you can unscrew it and put a new one on. Okay. When we first went needleless, we forgot. I mean, we were puncturing these things all over the place. Just making big messes. So we finally learned you don't need a needle anymore. Habits are hard to break. Okay, so you're going to draw up your meds with needles, but you can take your needles off. Okay. And then hook up there. That's for your pushes. Some of your tubing will have filters in it. Remember I said there's different types of tubing? Okay? This here is a blood tubing. It has a filter up here. It's like it's got 2 drip chambers. And I'll show you guys this next week. You have other kinds of, this I think is a TPN one, or a type of TPN. This is a type of dialysis, and I don't really know what that is. That one I don't know what that one is. I guess you could use that one for TPN as well. It's got a small filter there. Okay. But the tubing usually has the filter built in to it. But you may have to add, if you're giving blood to somebody and they need a special leukocyte type filter, that may be something that you have to connect to the tubing, and between the tubing and the patient, or the tubing and the blood. It just depends on what kind of filter that you need. Okay, but most of the time they're built into your tubings, and you don't have to fool with that. Right here's the drip chamber. Well, I'll try to show you one next Tuesday. If I don't show it to you next Tuesday, I'm definitely going to show it to you when we talk about blood. Okay. All right. Another device that you may see is called a Buretrol. Okay, this is a device that we use when we want to make extra sure that we don't dump a lot of fluid into our patient. Now, we never want to do that, okay? But sometimes dumping extra fluid into a patient is going to have a much greater consequence than with other people. Can you think of who? Children. Most of your children, infants, low weight children, very young toddlers. I know at my hospital, if they're below, I think if they were below the age of 8, they got a Buretrol, just automatically. Okay. They may have lessened that now. But what this does, your fluid is up here. Okay, your fluid, and this is built into your tubing. okay? But your fluid is up here, and you've connected it, and then down here goes to your patient. This is the drip chamber. But what you do is, between your bag and your Buretrol is a roller clamp. There's also a roller clamp down here to your patient. And what you're going to do is, you're going to prime this sucker first of all. Okay? Spike your bag, and then you're going to open this roller clamp, let fluid drain in. Then you're going to open this one and prime your tubing. Okay? Then what we do is, this right here is basically your IV bag. We program this. This will hold, I think, about a total of 150 milliliters of fluid. What we do is we usually drop 1 to 2 hours worth of IV fluid into this bag right here, into the chamber, clamp this one off, and then we let that infuse, and then we go back when that's empty and put some more fluid in it. Does that make sense? So rather than us draining a 1,000 cc bag, all that's going to dump into your patient, if God forbid something happens, is what's in this Buretrol right here. But what happens is, you've got to set your pump accordingly. Okay? If I'm going to set this right here, I think is my 100 milliliter line. Let's say I've got my 3-year-old's IV is going at 50 cc's an hour, milliliters an hour, sorry. I'm going to drop in about 100. Okay? I'm going to clamp that off. I'm going to open this because this is what I want to infuse. So what am I going to set my pump at? I'm going to set my pump at 50 because that's my rate. But then also on our pumps, we also set volume to be infused. So what is my volume to be infused? 100. Okay, my volume to be infused is 100. That means at 2 hours, when that sucker counts down from 100 to 0, this thing's going to start beeping. And I need to go in there, open up my thing, drop some more in, and reset my pump. Okay? Now, what you have to be careful with is don't over-program this. It's always okay if you want to set this for 90 instead of 100. You're basically just setting it so it'll beep so that you know to go back in there. If you suck this dry, sometimes this will kind of start to collapse on you. So you always want to under-program your IVs just a little bit. Even if you have a primary one hanging, okay, and you can set these for like 1,000 because there's always just a little extra in these, but it's okay if you want to set them for 950 as your volume to be infused, because when it starts getting down here and it counts down to 0, your thing's going to start alarming, and most of your pumps will at that time cut their rate down automatically to KVO. That's the nice thing about it. They don't keep sucking air, at 125 an hour, because then you go in and you've got air all the way down to here because your bag is sucking fumes, basically. Okay, so it's okay to under-program it a little bit. You're going to be the person chasing the alarm. Okay, but you do want to, in the case of a Buretrol, under-program it just a little bit. There is a place up at the top. Here's the top of the Buretrol here. There's the clamp that goes to the bag. Okay? So only one clamp at a time should be open. Either you're opening and dropping fluids, close it back, and then open it to your patient. There is a spot up at the top where you can, if you need to, you can put medications in there instead of hanging extra fluids for piggybacks. Mostly it's used for children. You could use it for adults, but mostly it's for children. We had a child one time that was about 4 years old, and she had cerebral palsy, really a severe case of it, and she had pneumonia. And she was really, really, really sick with it. And she, even though she was 4, she was about the size of an 18-month-old. She was little, long but tiny, little, just tiny. So she was so sick, she was on about 6 different types of IV antibiotics. And it was pretty much around the clock. We were hanging piggybacks on her. And she was getting on Q4 or Q8, and she got another one, she got Q12. I mean, we were hanging stuff all the time. So being that little, and she had fluids going anyway, we actually used her Buretrol as her piggyback. The thing you have to be careful with, though, is that when it comes time for her piggyback, you can't have this thing up here full. You see what I mean? Because if I'm going to put in medicine here, and this is full, and it's only going at, 10 an hour, there's going to be several hours, so that sucker's going to be empty, and then it's time for her next medication. So it was a process to make sure that when it came time for her medication, that we were empty down here, or pretty close to empty. But she couldn't tolerate all those extra 50 cc bags of fluid just because she needed her antibiotics. So it can be used that way, and it worked very well for her. So she was full up to here. It's just one of those respirations. It was constant. That's just, she was full. Bless her heart. Okay, so Buretrol's mostly for our children. In fact, that's all I've ever seen that used with has been children. Doesn't mean we can't use it for other things. All right, questions about anything so far?